and welcome to Cardio Buzz, your weekly cardiology podcast presented by Dr. Hussein Hishmat, Professor of Cardiology and Interventional Cardiologist. Every week, we refresh the busy doctor with a selection of practice-changing research, conference proceedings, guidelines, news, and interviews with experts. The podcast is available on Apple Podcasts, Google Podcasts, and Spotify.
Hi everyone, and welcome to the 12th episode of Cardio Buzz. And if you ask a cardiologist which organ interacts most with the heart, then the answer would be either the lungs or the kidneys. And cardiac interactions with the kidney are not only limited to pressures and hemodynamics, they are more intricate and deep. They involve hormones, neurons, minute-to-minute and day-to-day regulation of heart rate, blood pressure, urine output, autonomic nervous system, and cardiac function. These interactions are evident physiologically and are also very pertinent clinically. We know that there are at least 5 classic cardiorenal syndromes, acute and chronic. We know that the renin-angiotensin system, which is essentially a renin-induced mechanism, is activated as a defense system in heart failure. We know that kidney disease is a risk factor for atherosclerotic and coronary disease. Hemodialysis shunts have various effects on cardiac output. RAS blockers, spironolactone, diuretics are essential cardiac medications that affect the kidneys in different ways. And we are lucky that we are living in time where new agents are coming that can benefit both renal patients and cardiac patients at the same time. And to discuss these issues, I'm glad to have one of the eminent nephrologists in the region, Dr. Nizar Atallah. Dr. Nizar is currently a consultant of nephrology in Cleveland Clinic, Abu Dhabi. He had residency training in internal medicine and nephrology fellowship, hypertension, kidney transplantation in Henry Ford Hospital in Michigan, USA. Then he became an associate professor in the University of Kentucky. And then he was promoted in 2020, clinical professor of medicine in Cleveland Clinic, Learners College of Medicine in Cleveland, Ohio. Dr. Nizar is well known, of course, for his work in resistant hypertension, kidney transplantation, chronic kidney disease, and cardiorenal syndromes, with dozens of publications in these fields. So I'm glad to have you, Dr. Nizar. Welcome to our show.
Thank you, Dr. Hishmat, for the invitation and the introduction. It's very nice to be with you today. As you mentioned, there is a lot of interaction between cardiology and nephrology. We share a lot of patients, and we are discovering over time that a lot of therapies are common to both specialties, like RAS inhibition, as you mentioned, mineralocorticoid receptor antagonists, and SGLT2 inhibitors. The most common cause of death in chronic kidney disease, dialysis, and kidney transplant patients is cardiovascular disease, as you know, and we need to work together to improve that. There's a huge field of cardiorenal medicine that's developing, and we will be working more and more together to address these issues.
Exactly, Dr. Nizar. You started by exactly what I wanted to say. We need to be working as a team, not as silos, not just looking at the serum creatinine or just looking at the ejection fraction and focusing on that. So my first question, how do nephrologists look at cardiovascular risk? From the cardiology point, whenever we see a patient with chronic kidney disease, we know that there is some vascular disease in the coronary, in the periphery. What's the nephrologist's take on that? How frequently do you prescribe statins, aspirin? And do you routinely refer a patient with chronic kidney disease to a cardiologist even if he's asymptomatic?
So as you know, our patients, they have traditional risk factors for cardiovascular disease and non-traditional risk factors. Traditional risk factors like diabetes, hypertension, hyperlipidemia, smoking, and family history of cardiovascular disease, plus sedentary lifestyle. This is common to any patient, but we also have non-traditional risk factors like you mentioned earlier. For example, our patients have higher oxidative stress, more inflammation, vascular calcification, especially medial calcification different than other patients who have intimal calcification. Anemia is another major issue that's very common in chronic kidney disease patients and increases the risk for cardiovascular events. Normally, when we see our patients, we try to address those issues as much as possible with our patients. Now, for hyperlipidemia, statins are widely used in chronic kidney disease patients at different stages, mainly because of lower cardiovascular events that were shown in some studies. For example, the SHARP study, I'm sure you're aware, had patients with chronic kidney disease at different stages and patients on dialysis. Patients on chronic kidney disease had benefit from using statins, and that's one of the reasons we use them. Also, they help in proteinuria control, which is a major problem in our patients. Planet 1 and Planet 2 studies showed clearly that atorvastatin helps with controlling proteinuria. Also, statins are widely used in kidney transplant patients. ALERT study showed benefit in those patients, even if their cholesterol is not elevated. It improves the graft survival. Now, unfortunately, studies were very negative in patients on dialysis. So we have the 4D study that looked at atorvastatin in dialysis patients. We have the Aurora study, looked at rosuvastatin in dialysis patients. Even the SHARP study had about 1/3 of the patient on dialysis, and all of these did not show benefit in dialysis patients. So normally, if a dialysis patient is not on statins, we do not necessarily start it unless they have a cardiovascular event, or if they were on it in the past, we do not stop it. Now, aspirin use is like the general population, basically. So we use it usually for secondary prevention. We used to use it in the past for primary prevention, but as you know, like in the general population, we don't have evidence that it helps. Sometimes we use it to help the patency of AV fist in dialysis patient, but the data on that is very limited. Now, as referral to cardiologists, of course, we refer sometimes depending on the patient's symptoms and how bad their situation is. If they develop a cardiovascular event, or we see that they are getting worse, especially having dyspnea on exertion, we have positive stress tests, of course, we refer them to cardiologists to be evaluated. We try to work together as much as possible in terms of choosing the best stress test to be done, in terms of timing, the heart catheterization, and choosing the best therapy for the patient.
Very good, Dr. Nizar. So in your answer, you added a few more points to the interaction between the heart and the kidney, that statins can reduce proteinuria and they can preserve the patency of grafts, and that's wonderful. My second question is, we are sad that as we grow older, our kidney functions tend to decline. And recently, we only had RAS blockers that can slow down the progression of chronic kidney disease. But now we are living in exciting time because we are at least having now 3 agents on the horizon that can protect the kidneys. So we can take them one by one if we can. Let's start by finerenone. We're hearing that name coming frequently. What's that, and how different is it from the regular mineralocorticoid receptor antagonists? And what evidence and what promise does this molecule bring?
Now, as you know, one of the major problems that lead to kidney disease, especially diabetic kidney disease, is fibrosis and inflammation. Just like this contributes to heart disease and worsening heart failure, this also contributes to worsening kidney disease, especially diabetic kidney disease. In general, diabetic kidney disease pathophysiology includes hemodynamic, metabolic, and fibrosis factors. Studies in the past used to concentrate on metabolic factors like controlling diabetes, especially with different agents. Hemodynamic factors like using RAS inhibitors, and more recently SGLT2 inhibitors. Unfortunately, most of the studies that were looking at inflammation and fibrosis were negative. Spironolactone, we had a lot of interest in it, but the major problem is hyperkalemia. Now, finerenone is a very interesting molecule. First, it's a non-steroidal mineralocorticoid receptor antagonist. So it acts on the same receptor like spironolactone, but it's not steroid based. So because of that, it causes less side effects. So for example, hyperkalemia is much less. Also, gynecomastia is less, and other side effects are less than spironolactone. Now, in terms of studies looking at finerenone in diabetic kidney disease, there are two major studies that were published not too long ago, the Fidelio study and the Figaro study. Fidelio is about 5,700 patients, all diabetic kidney disease patients. In fact, even Figaro is almost the same design, diabetic kidney disease patient, but included more patients, about 7,400 patients. Both studies included patients with GFRs about 25 to 75, and they needed to have albuminuria, at least microalbuminuria, but it extended also to macroalbuminuria. So they had to have urine albumin anywhere between 30 to 5,000. All the patients to be included in the study, both studies actually, had to be on RAS inhibitors. So finerenone was used as an add-on on top of RAS inhibitors. Fidelio looked mainly at the renal outcomes and looked at the cardiovascular outcomes as a secondary outcomes. Figaro was the opposite. So it looked at cardiovascular outcomes in those patients as a primary outcome, and the renal outcomes were secondary. Both studies were very positive, and there are more studies are being done looking at those patients, actually expanding even studying finerenone into other populations like heart failure population, like non-diabetic chronic kidney disease patients. And so we are very excited about this molecule. We're hoping it will prove benefit to even wider population outside diabetic kidney disease. And the fact that it causes less hyperkalemia is very helpful for our patients.
Okay, so we're having a refined an evolved form of mineralocorticoid receptor antagonist that protects the kidney and protects the heart, whether diabetic or not, and with lower chances of hyperkalemia, right?
Yes, of course, yes.
Okay, so that's the first molecule. The second molecule is now well known, which is dapagliflozin. And this molecule moved from endocrinologists then to cardiologists, and now it's in the lap of nephrologists after the DAPA-CKD trial. So how do you see this molecule, and how should it be adopted in clinical practice?
So, SGLT2 inhibitors work on the proximal tubule in the kidney. Initially, they were invented to be diabetic medications. Basically, they block glucose reabsorption, and with that, they cause glucose loss through the urine. And we thought because of that will help controlling diabetes. But these medications, they have a lot of other benefits. And over time, with the different studies on dapagliflozin and other SGLT2 inhibitors like canagliflozin and empagliflozin, the evidence is showing benefit, cardiorenal benefits, both to the kidneys and the heart. Now, the mechanism, as I said, the initial mechanism we thought about is increasing glucose excretion, but we recognize also that sodium is lost too with glucose, so there is natriuresis. And then, there are other important mechanisms. We don't really know which one is more important than another, but there is a switch in energy expenditure. So the organs, especially the kidneys and the heart, instead of relying on glucose, they start relying on ketones, so they become much more energy efficient. Also, there is lower oxidative stress because of those medications. They improve hemoglobin, they lower uric acid. So all in all, they have multiple benefits to both the heart and the kidneys. We know there are shared risk factors between the heart and the kidneys, and this family of medication helps significantly. Now, as you know, empagliflozin, dapagliflozin, and canagliflozin were studied mostly in cardiac patients, and then there were secondary outcomes looking at kidney outcomes. Dapagliflozin and canagliflozin both have studies looking at renal outcomes as primary outcomes. Dapagliflozin had the latest study, which is the DAPA-CKD. It included about 4,300 patients. The follow-up was designed initially to be about 4 years, but then the study was stopped earlier because of overwhelming benefit. The nice thing about this DAPA-CKD study that it included diabetic and non-diabetic patients, just like the DAPA-HF and down the Emperor Reduce and the Emperor Preserve, that included even patients down to GFR of 25 with albuminuria. All patients needed to be on RAS inhibitors. Significant improvement. We're talking about 38-39% improvement in renal outcomes, whether we look at doubling of creatinine, requirement of dialysis, or transplantation. The nice thing, there are more and more studies coming out. EMPA-KIDNEY was just stopped recently, and hopefully we'll have some results in the near future.
Yeah, I read in the news a few days ago that the study was again stopped because of overwhelming benefit.
Yes. So EMPA-KIDNEY, we're expecting it will show similar results to DAPA-CKD. The nice thing about EMPA-KIDNEY, it included more patients. It's about 6,500 patients. EMPA-KIDNEY also included wider population. So DAPA-CKD and Credence. Credence initially went down to GFR of 30. DAPA-CKD went down to GFR of 25. EMPA-KIDNEY goes down to GFR of 20. Also, it's including diabetic and non-diabetic patients, and also at the same time, it includes patients even with normal albuminuria. So we are expecting, if the results are really positive, that it will expand the use of SGLT2 inhibitors to even wider population, especially with chronic kidney disease.
That's great. So now we're having like 3 agents that can help renal patients to slow down their progression of disease: finerenone, dapagliflozin, probably empagliflozin as well. Do you see any drugs or procedures coming in the pipeline also, Nizar? There are, unfortunately, our patients are very, very complex patients. And over the years, we had multiple negative studies. The problem is normally we try to concentrate on one mechanism, looking at one medication versus another, and usually that showed negative results. Now, there are some studies ongoing in the field of nephrology. There are some exciting results, hopefully, over the next couple of years. Now, in the field of chronic kidney disease, diabetic kidney disease, endothelin antagonist is the one that's being studied now, and hopefully it will show some good results. When we look at the field of end-stage renal disease and transplantation, xenotransplantation and artificial kidneys are being studied heavily now. Even regeneration of kidney tissue is being studied heavily. So that has a lot of good future. When we look at glomerular diseases, for example, affecting the kidneys, there are new immunosuppressive medications that are being studied, trying to help control these glomerular diseases and prevent progression of those diseases into chronic kidney disease and eventually end-stage renal disease. So there are studies ongoing. Unfortunately, because we had a lot of negative studies in the past, we don't get excited easily with one study or one short study. We were trying to wait for longer studies and bigger studies. But for sure, there are some exciting things happening. And over the next couple of years, we'll have more medications that we can use for our patients. We hope for the best, Dr. Nizar. My last question, and it would seem a bit basic, but it's important because the holy month of Ramadan is approaching. And so what should the physician tell the patient who has chronic kidney disease? How should he counsel him on fasting in Ramadan?
So, unfortunately, this area is not well studied, but of course, we have information from smaller studies. In general, when we counsel our patients, we look at their kidney function for sure, but we also look at other risk factors. So, for example, a diabetic patient, especially uncontrolled diabetic, we don't necessarily wait till their kidney function is so bad before we advise them not to fast. But in general, if somebody has a GFR of 45 or above, in general, it's safe for them to fast. We always recommend to the patients to drink enough fluids between iftar time and suhoor time, which is between the sunset and sunrise. And we work with them and counsel them on how to distribute their medications at night instead of throughout the day. Now, if somebody has a GFR of 30 to 45, here we look at the other risk factors. If they are diabetic, how good the diabetes control is, if they are hypertensive, if they have heart failure, if they have volume overload or not. So in general, patients between 30 to 45, if they do not have a lot of risk factors and they are stable, they are able to fast. But we also tell them, we have a low threshold to break your fasting because we don't want to cause any harm or worsening of kidney function. In general, this group of patients, if they want to fast, we ask them to repeat their kidney function about 7 to 10 days after the start of the holy month, just to make sure their kidney function is stable. And if it is stable, we tell them to continue to fast. If we notice worsening of the kidney function, then we tell them typically to stop. Now, the third group is patients with GFR of 15 to 30. In general, we tell those patients to not to fast, but we have a group of them that insist on fasting. If they are stable and they know how to manage their fluid intake and they know how to manage their medications, we tell them it's better not to fast. But if they insist, we tell them they can do it. But we also have a low threshold to break the fasting and also check their kidney function a few days after they start fasting. The last group of patients who are having a GFR under 15 or they are on dialysis, we normally recommend for them not to fast because the fluid management and the shifts that happen in dialysis are significant, and they could get dehydrated very easily. They need to have enough water intake, and also they need to take their medications on time, sometimes before dialysis, sometimes after dialysis. It will be very, very hard to do it with fasting. So all in all, we look at the kidney function, we look at other risk factors, try to work with them to distribute the medications right, distribute their fluid intake right, and we try to individualize as much as possible. Sometimes even patients with GFR of 60, if I see that they have uncontrolled diabetes and I know that they got admitted more than once over the last year with changes in the volume status, whether it's dehydration or hypervolemia, I advise them not to fast. So we have to individualize as much as possible.
That was a brilliant review of the impact of fasting and the different thresholds, 45 and 30 and 15 and dialysis. This was great, Dr. Nizar. It's the first time I hear this detailed scientific explanation and advice for patients with chronic kidney disease. And honestly, I enjoyed this interview, Dr. Nizar. I learned a lot, several new points, new hopes for patients with chronic kidney disease, finerenone, dapagliflozin, empagliflozin, when to fast Ramadan, when not to fast. It was great having you with us, Dr. Nizar.
Thank you, Dr. Hishmat. I really appreciate the opportunity. I would like to thank you for the invitation, and I'm sure we'll have more and more opportunities over the next few years to discuss and address more issues that are common to cardiology and nephrology. More importantly, I hope more and more therapies will become more available, and we'll be able to work together as we started with as a multidisciplinary team to help our patients and improve their outcomes.
Definitely, Dr. Nizar. Thank you again for accepting our invitation, and see you again soon in the future, inshallah. Thank you, sir.
Thanks a lot. Thank you.
Thank you for listening to this episode of Cardio Buzz. If you like the content, follow the show on your favorite podcast platform: Apple Podcasts, Google Podcasts, Stitcher, and Spotify. You will find previous episodes and get alerts to new ones. Please rate the show and write your own review of the content. You can share the episodes to spread knowledge and benefit. Enjoy your weekend and see you next Saturday.